Good afternoon, everybody. My name is Christopher Shanahan. I'm a general internist and addiction doc. I work at Mattapan Community Health Center as a primary care physician and addiction physician, and I'm a clinical associate professor of medicine at Boston Medical Center in BU School of Medicine. Today, I'm going to be talking to you about how to manage your professional risk when caring for patients with OUD or chronic pain. Another way to think about it is how to get in trouble with the DEA and bore them. So it's an odd topic, I agree, and I came to it by an odd way. So, which one? I'm just going to get you a better mic. Okay. So these are our learning objectives, which I'll allow you to read. Hopefully, you'll know a little bit more about this by the time you're done. And I'm going to do a shameless plug real quick. I'm also the medical director for the Massachusetts Consultation Service for the Treatment of Addiction and Pain. And I'm lucky to be here with a couple of my colleagues who also are consultants with it. Phoebe Cushman is one of our consultants, and I'm having stage fright all of a sudden. Jessica Gray is also one of our consultants, and Rachel King is here, and Mia Sorcinelli Smith is here, and I'm here. So there's a bunch of us here. Anyway, let me tell you quickly about McSTAP if you haven't heard of us. We are a live telephone support program to support clinicians in the state that are prescribing and taking care of patients with OUD, with any substance use disorder or chronic pain. We provide weekly telephone support 9 to 5 to anybody who calls us. Usually clinicians call us, physicians, nurse practitioners, PAs, but we get calls from social workers and administrators all the time. What we do is we support you in making decisions and trying to figure out how to treat and diagnose your patients with chronic pain and or SUD. All of my consultants do that in their regular work time, so that's their jobs, and they all really practice, so they understand the actual problems that are coming to you in the setting that you're at. Because they're practicing, they understand that you have time constraints, and so our consultants work within those time constraints. In addition, we also have other expanded services. We can provide mentoring to you if you or your colleagues, if for some reason you had a bunch of patients that you wanted to do a deep dive on, or you were inheriting a panel of patients that have a lot of chronic pain or SUD, and you wanted to do a deep dive and wanted some mentoring to do that, we can provide that free of charge, and we will also be able to offer CME for that. We have a monthly webinar. We also offer CME. And then we can also come to your organization and provide training and educational services, both to your staff, if you have a training program there, to your trainees as well. And then finally, we can also provide some practice support to help you with improving systems. So that's McSTAP. Let me tell you a little background about how I got to come to speak about this topic today. So I've done some forensic views for private lawyers and for medical state investigators over the years. I haven't done any recently, so I didn't put it on my disclosures. I haven't done any in about 4 or 5 years. I've also had the experience of having been audited by the DEA, which was an interesting experience just before the pandemic. Not because I was doing anything wrong, it's just came up on the list. So I'm going to share that with you as well, a little bit of that. What I'm going to be explaining to you today is, you already know all of this, all right? So there's going to be no revelations here. You all know this stuff. What's fascinating is that we got to repeat it. And on top of that, and that some people don't know this stuff. And one of the other reasons to tell it to this group is that many of you are teachers and educators, and we need to pass this message along to the people that we train. So in some respects, it's going to be lost on you, but in other respects, hopefully it'll remind you how important this is and how much it needs to be kind of front and center in our practice. Okay. So the environment is that the care that you provide can be evaluated for non-clinical purposes by medical boards, malpractice suits, or even DEA investigations, all of which, I'm going to stop for 1 second. Can you help me with this? There's something in front of my screen, so I can't, that person is there. Okay, thank you. I was afraid to touch anything. All right. So all sorts of people can look at your charts and your medical care for all sorts of reasons, and they all have different agendas. Medical boards and malpractice cases tend to focus on standard of care. So they're trying to figure out, is this person doing what a normal doctor would do in a normal situation for this type of patient? So they tend to fixate on that, and they tend to be more focused on clinical guidelines and what would a reasonable person do in this situation? It's very medically oriented, and it's much more the way we think as clinicians. The DEA comes at it from a totally different angle. They are a law enforcement organization. They are thinking about supply side, interdiction. They're thinking about breaking laws. When they think about us, they see us as just a source of diversion, okay? They don't see us as, the guys that are writing the scripts intentionally most of the time. That's not really, they're not that too much worried about that. That's a small percentage. It's the other one. So when they come in looking for you, they're not going to look they don't look at what you're doing. Or should I say, they're not looking at your medicine or how you're practicing. They're looking at how you're managing the system. So they want to see, when I got seen by them, they wanted to see my registry. They want to see all the patients I've. Can you tell me who you're taking care of? Who are they? They want you to know your patients and to monitor them enough so that supposedly you can notice diversion. Now, that's not our job, but that's what they think it is. So that's their mindset. At least that's how I interpreted my interactions with them, because their questions were always focused in that direction. Talk to a DA agent, you may get a different perspective, but that's what I felt from it. They were very concerned. And so if you're working in a setting that doesn't administer, then it's really about documentation. When it's administering, then they get into documentation, and they also want to see how you lock things up, because then you're talking about stealing things. And then they go to another level of paranoia. But unless you have narcotics and you're administering narcotics on your site, you're not going to have to deal with that. OTPs obviously are a different situation. Okay, so they're focused on the laws, and they have the tools to find out if something's on. So it's not like the board, where the board will have an investigator. That's about it, right? They'll ask some questions. These guys are like cops, so they can stake out your property. They can bug your house. They can go in and take your records. It's a totally different animal. Anyway, let's talk about the key piece. This is the issue. Now, most of us do electronic records, but I'll bet there's one or two of you guys that are still on paper, okay? Don't get thrown off by the paper. Even electronic records, if they're not done correctly, can look like this. So this is what I saw. I was working for the Borum at one point, and they gave me 2,000 pages, and I got to go through 2,000 pages of this, okay? So, I mean, holy cow. So let me just tell you, as a person who was charged with trying to figure out what this person was doing, let me tell you what I was looking for so I could figure it out, okay? But this is the problem when it comes to documentation, and this is how you get into trouble. And we could just talk about this one slide for hours. Okay, so first of all, the clinical risk, it's all in your notes, okay? Because that's the only evidence that's there. What you did is gone. Nobody cares about what you did. It's just they care about what you wrote down, okay? So basically, there's three things I was looking for as, I'm going to call myself, I wasn't an investigator. I was paid to do this, a reviewer. I was looking for basically three things. Was there a plan? Is there a plan? Now, ask yourselves honestly, have you articulated a plan? Really? Not just, we're going to start meds, but what's the plan? And is that plan obvious? And is it being touched upon or mentioned as you go through your notes? Yeah, it doesn't have to be a big, long, it could be just one sentence or even a few words. But you need to remind yourself and the people who are reading the chart that there actually is a plan. And there's a reason why we're doing this. And at some point in the chart, you've got to provide the rationale for doing it. I have done lots of chart reviews, never saw the diagnosis being clarified, ever. It just, they have the pain and the meds come. Nobody knows what's going on. So a lack of a focused treatment plan is usually a big issue. What you'll find markers of that are missing or incomplete diagnosis, okay? There's no substance use history, there's no pain history, no functional goals or milestones, no long-term dose. The person remains on long-term on high-dose opioids with never a statement of reconsidering the dose, how well they're doing, should it go up, should it go down, nothing. And then evidence of referrals to consultations that never get dealt with. They go to the pain clinic, they come back, nobody follows the recommendations, or the patient was referred, only went once, didn't finish the PT. No repercussions, no follow-up. That's all lack of focus. So when I'm looking at charts and I'm looking for risk and trying to figure out what this doc is doing, if I see this, this is going to be like, oh, this is not good. So that's one way you get in trouble. You have to have a plan that makes sense. You have to have evidence that you're actually paying attention, not just at the beginning, but over time. You have to have evidence that you're monitoring and that you're reassessing, and that that there's an interaction between you and the patient, and things are occurring. The last thing is writing it all down. So you got to do the stuff, you got to think the stuff, then you got to write it all down. And the charts that just didn't cut it and got this person into trouble were, there's no detail. You saw that note. There's no responses from the patients. There's no rationale for what you're doing. There's no longitudinal tracking, and there really is very little documentation of any of the safety practices. Urine drug screening results, what was thought about it, how it was interpreted, what was done. Here's how you get in trouble. Don't do any of that. Don't do it. Don't write it. You'll go right to jail. All right? Because the minute they pick up your chart, they're going to get somebody like me who's going to say, like, what the hell's... There's no evidence that there's any process going on here. So all of this adds up to poor analysis and poor decision-making. If you can't manage the data, if you can't articulate a plan, and you can't monitor it as you go forward, you're not going to analyze it well, and you're going to make bad decisions. So I know it sounded out like, how do we stay away from the feds, right? How do we stay out of trouble? But the truth is, you do this and you're going to provide good quality care because you're just doing the stuff you're supposed to do. The only added piece is you're documenting it so you don't get in trouble. So all of this can lead to really bad decisions. If you're not monitoring somebody's dose appropriately, maybe you'll never think about adjusting the dose or lowering the dose. If you're not following up on consultative results, then consultative recommendations, that patient may not progress. So, and then I think finally it leads to basically, and this is the other thing I was looking for, okay, when I was doing these reviews, is I was looking for reflective practice. Some evidence that the person realizes that they don't have all the answers and wonders, is there another option? Or maybe I'm doing something wrong. A good physician will question that. A better physician will write it down. So I look for that. And it's important to see, especially with patients that have so much risk and there's so much uncertainty, we should be uncertain and we should write it down. At least at a point that it helps us. So how do we combat all of this bad habits? So, it's basically we do risk assessment and monitoring at every visit. Every visit is a scramble to collect critical information about this individual that will help keep them alive for the next visit. And doing that really demonstrates a safety-focused approach. It's really patient-centered because you're really focused on making sure the patient succeeds in doing this. So you should be documenting monitoring activities at every visit, assess the clinical status and progress, say how the patient's doing. Are they doing better or worse? Because once you make that assessment, it justifies the next step. Sometimes I don't see assessments. There's no just says raise oxygen. Why? There's no argument. There's no pain. There was no evidence that the PT was helping. It was just an elevation of pain meds, and it wasn't justified. Record discussions and decisions. and then monitor clinical outcomes. I also recommend to the bad thing to do. But I also recommend, for many of you are on EHRs, create a template that reminds you to ask the same right questions. Okay, and then obviously do frequent assessments. So another aspect of how to stay out of trouble is the question about what is a safe dose. And that often came up when I was doing the reviews. These people were on meds, and the DA or the lawyer wanted to make an argument that was a safe or unsafe level, but it wasn't being monitored correctly. Now, I don't need to tell you all this, but I'm putting it out there because we have to. There is no safe dose, obviously. We all know that. People can be on very high doses, but who are stable and very strong in supportive situations, and the risk there is extremely low, and vice versa. So I don't need to belabor the point, but what it brings up is every decision is a risk, it's a risk-benefit decision. And that's part of this, is that the risk-benefit analysis really informs keeping yourself out of risk. So for example, in practice, we have a high-dose patient, right? Such a high dose is only appropriate if you have documentation and evidence that the pain control is required for pain control. That's documentation, right? Quality of life, meaningful improvement in daily living. You're looking for that. That's the risk-benefit ratio, right? That you're looking to kind of get in the right direction, and that justifies the medications. And then function, you're looking to monitor function. All of this is towards the standard of care. The standard of care is to constantly reassess these harms and benefits. So our job is to constantly do the risk-benefit analysis. And if you do that, you will mitigate your risk personally because you're constantly looking for ways to keep the patient safe and do what's appropriate. Failure to reassess or to document it is not the standard of care. It's, again, a simple statement, but you'd be surprised. I'm not an expert on the DEA. What I wanted to transmit on this page is that the DEA has lots of tools to track us down. They have lots of ways to figure out what's going on. And so you just need to be aware of that. Again, they're very focused on diversion, and they only see us mostly as a diversion problem. Okay. Borum. Borum's a little different. They're the complaint. Well, first of all, back to DEA. Complaints come to the DEA in a variety of ways. They can come through agencies that notice abnormalities in drug prescribing. It can come from a pharmacist. It can come from a variety of different locations. They generally don't come from patients. Borum complaints, though, come from patients or from colleagues. They can come from families, even from pharmacies. Piss off the pharmacist on the phone, you can get a complaint to the board. So disagreements or patient dissatisfaction can lead to a complaint. I mean, it seems kind of crazy, but you can piss somebody off in clinic, and next thing you know, and it could be around opioids, and next thing you know, they said, that doctor won't give me opioids. I have a chronic pain. This person is mistreating me. Next thing you know, you have a board complaint. It's that easy. All you need is a slightly educated and motivated patient. You got a board complaint. So we'll talk about that in a second. More serious complaints can come if that relationship is strained on top of it. So if the relationship is even worse, then you're even at higher risk. So what's the good news here? Most board complaints from patients are usually trivial. They usually come down to he said, she said, and they're personal. And it's usually behavioral stuff. So most of them get swept under most of them get dismissed. But if they don't get dismissed, they don't go away. And they constantly get in your way. I happen to sit just by accidentally, I happen to sit on an insurance credentialing board. And we're constantly credentialing people, and these board complaints come up, and one is no big deal. 6 of them, because the patients are complaining about the same kind of stuff. Wow. all of a sudden now, we're not so sure we want that person on the insurance. So this stuff can catch up to you in ways that you may not realize. Onesies and twosies, no big deal, right? But you start getting multiple board complaints around the same stuff, you're in trouble. They're going to find you. So what do we do about this? It's just about optimizing the clinical relationship with the patient, right? First of all, it's between you and the patient, right? If you guys are not getting along or there's no trust, then if anything goes wrong, boom, something can happen. So you want to show respect and avoid judgment, something we have to think about all the time in this business. We want to provide evidence-based care. We want to document clearly. Patient treatment agreements are important. Again, they're not legal. There's no evidence they work, but they're good common sense. And it gives you an opportunity to talk to the patient and to revisit those conversations in the future about safety and ways to get things done. Maintain a registry. At least for the DEA, they want you to have one. Now, you probably all have one now because you're almost all on EHRs. If you don't, an index cards will work, okay? You don't want to go crazy. They just need to know that you have a list and you maintain it and that you know who, so that when they walk in and they say, I want to see all your 5 patients, it takes you 10 seconds to produce it. You do that, they'll leave you alone, I think. They'll let me alone. Make sure your notes are appropriately detailed. Use templates when you can to help you, okay? Take the DA audit seriously. And remember, patients sense judgment. It erodes trust, and it can trigger complaints. So in conclusion, to mitigate your professional risk when caring for patients with OUD and chronic pain, it's important to provide patient-centered and evidence-based care and document it systematically and reliably. And then if you're in a jam, call us, McStapp. We'll be happy to help you. I could take questions. Simple topic, there'd be no questions. You guys all know how to do physical exams.
Sorry, I have many questions. YSAM Lee from Mass General. We have many of these cases, and I think a lot of us feel the discomfort, and we really appreciate having guidance and support from all around our community. It's really wonderful. I've struggled for a long time about the documentation. Sometimes I honestly think in my head, do I want to write this down? You know, the patients and what they're doing in their lives, or there's legality, IPV risk, all sorts of things. And so maybe start with the easiest one. If, you know, we just came from our OTP conversation around, we know the folks are actually actively using, we're trying to get them to care. So with the UDS, last year we had a lot of spicy debate around doing tox screens. If I don't have a tox screen, am I documenting? I don't have a tox screen because I know for a fact that he's using, because he told me he's using. And I'm trying really, really hard to connect him to care. Or do I use my dot for age, which is like, the patient is on chronic opioids, so there is significant risk-benefit ratio considered.
Yeah, I mean, we are living. We are always, this is not unique to this problem. There are people that had HIV that didn't want that in the record. I mean, there's all sorts of information that people don't want in the records. And unfortunately, it's left to us to make clinical decisions on the spot about what's appropriate and what's not. And what goes into that is, what do I need to know clinically? What do my colleagues need to know clinically so that this patient is safe in the future? And then, you know, but how much risk do I want to put my patient by exposing their private stuff, which supposedly is undiscoverable, but nowadays, who knows?
With the CARES Act, it's been extremely difficult. In the last few years, my patients don't want the word fentanyl in their charts at all. They see their notes, right? So I can't write that I know that they have fentanyl use disorder because they're reading their note and saying, I'm not going to tell you that. And that makes it less safe.
I mean, it's, you know, loss of trust in our society is a very corrosive thing. And I think we are finding how much trust is integral to us, our ability to actually function as a society. And as we lose trust, our patients are they're gonna not benefit from that. They're gonna suffer from that.
So should I write that I know the patient's actively using?
I would suggest you come up with some code that you know and other people know, but the feds don't know, unfortunately.
Hey, Chris, thank you. It's Ken Grossman. I work at BMC. Up until a few years ago, this was actually first part of what I want to say was really a comment and a plug for you guys at CSTIP Mixed Step. Up until a couple of years back, I was doing only primary care. And like most of us, I inherited a number of patients with with opioid use and chronic pain, and really felt not very empowered and worried about how to handle these folks. And I don't remember exactly how I found out about Mixed App, but I called a number of times. I can think of at least 3 or 4 patients that I called, and it changed my practice life, right? It really empowered me, and it actually created a budding interest in addiction, which is what I'm doing these days as a part-time, mostly retired doc. The question I had though is,
Hold on, let me write a check for you.
6 figures, please, will do. So the question I had though, in terms of reducing risk for people who are taking care of these patients still, do you advise that if a consultation with Mixed Step is conducted, is that documented in the chart, and how much detail? And then the second part of that question is, what's the risk to the consultants at Mixed Step for providing those
That's a good
that
question.
information?
Those are good questions. So as far as what do you want to write in the chart, write anything you want. You can say you spoke to us, you can give I mean, that's fine. It's totally fine. Sometimes we will get a call and they will want us to send them a text of something that says, what, either the plan, or sometimes they just write something like, I spoke to Mixed App and they said that's what I should do. It's very exculpatory, people are going to do what they're going to do. We hope that as far as us having any liability, the Mixed App program actually grew out of previous programs. There was a child psychiatry access model. It provided consultants for pediatrics for behavioral health because pediatricians did not have access to psychiatrists for like ADD and stuff. And so they came up with this program of getting consultants to PCPs. They've worked out all the legal stuff because we just keep records, but it's only for verbal continuity, so our consultants can know what's going on between patients, but it's not discoverable and it's not a medical record. So we're not at risk for it, and it's been through the lawyers several times, and the program's been around for 20 years. The McPap model has been around for 20 years, and it's been okay. So hopefully that answered your question. Yeah. Yes.
Michael Medlock, I was wondering if you could say a little bit more about documenting uncertainty in the chart. My sort of MO has been to keep those conversations private with colleagues in M&M and quality assurance conferences, and not put that uncertainty into the chart where the patient can read it and say, what do you mean? You don't know what you're doing? And, when you're thinking about, okay, this patient has overdosed on high dose opioids, you think they need to come down, but they are vehemently against. So you're balancing, do I risk a Borum complaint, or do I risk an overdose, or do I risk suicide because I won't give it to them? Those kinds of things are very charged, and I think could really cause a problem in a deposition.
Yeah, I mean, I think you have to be very careful when you're writing, when you're documenting complex discussions with patients around dosing, especially if they're fraught conversations. I don't have a problem. I mean, it's my personal opinion. I don't have a problem writing down if I'm not sure what the right direction is. I know the way I usually phrase that is options are. I don't say I don't know what's going on. I say these are the options. So, but the next thing is I try to act on those options. So I'm not sure I'm answering your question, but it's a tough one because some of the data that we do deal with is extremely sensitive. And when patients have an issue with it, it gets in the way of our ability to kind of manage the data too, because I'm not going to remember that if I don't write it down. So, anyway, thank you.